Welcome back to the Lift Free and Diet Hard podcast. I'm your host, Andrew Coates. Join me along with industry leaders and friends on a quest to get more people through the gym door and eating and living healthier. Join me where evidence meets empathy while rejecting fitness industry fads and extremism. Let's begin. All right. I'm a big fan of your name, Willey, which is amazing. So I feel like Patrick Stewart, and you're coming in to kind of screw with me. That's a Star Trek The Next Generation reference. If you guys get it, great. If not, I'm so sorry, right? Or maybe we kind of go Free Willy, but you're neither of those things. You are a doctor of physical therapy, a certified strength and conditioning coach, which is my favorite combo in all of rehab and strength training, plus a master's in exercise physiology. It's like, holy shit. You've actually authored papers. You've been in the research. You've played and coached at the college level in strength and conditioning. And you have collaborated a whole lot with one of my favorite rehab professionals and a previous guest, Dr. Katie Dabrowski. So that's quite the resume. Thanks for coming on.
Absolutely. Thanks for having me. This will be fun.
Okay, let's dive in. Quote, the number of studies finding squats and deadlifts are the cause of back pain equals 0. Talk to me about that.
So I think that just comes from, there are so many claims made from both the fitness side of things, even on the healthcare side of things. I mean, I've heard lots of people will go and see an orthopedic surgeon and a physician, and these folks will make these claims that these things are dangerous. Weightlifting, specifically heavy barbell work, causes some kind of axial load that is far more injurious than any other thing that could possibly be done. And that's just not the case. I think all too often people may become injured doing one of those things just because it's a fairly common thing to do. And then they blame the exercise because of a lot of the heuristics and societal norms. Yet when we look at the epidemiological studies of people squatting and deadlifting, even very competitively, it just doesn't really add up to that. And I think that, like, the common analogy that I use is that if somebody hurt themselves, like say you hurt your back having sex with your partner, does that mean that you're just going to never have sex ever again? Probably not. But for some reason, we've put weightlifting and like deadlifting and squatting in this like very dangerous, injurious category, even though like pick up basketball, pick up soccer, ultimate frisbee, even riding a bike recreationally has been shown to be far more likely to cause injury than other things. But it's just, there's like such a fear around it that we've created societally that I think they get put on the pedestal they don't deserve.
Pickleball, injury rates in pickleball.
Yes.
Right. So what are the actual considerations? Because I mean, I could throw the word load management out there, and I think the indoctrinated listening will know exactly what I mean, but perhaps you'd explain that. And then I have a few thoughts I'll throw in later, but what really are the mechanisms presenting for injury risk here?
Yeah, I think one of the biggest things that Katie and I talk a lot about is basically the preparation, the idea of you're underprepared to do the thing that you're asking your body to do. When we talk about load management, you know, a lot of the conversation around load management and the acute to chronic workload ratio type stuff was popularized by the Australian researcher Tim Gavitt. Some of that research has, you know, either been questioned. And I think that over the last maybe 5 to 10 years, there's been some ebbs and flows, but what we see in terms of, especially when it comes to sport and when it comes to endurance athletes or recreational, even gen pop athletes, that typically if you're exceeding volume by about 30% in a span of somewhere between 2 and 4 weeks, you are going to run the likelihood of an increased risk of injury. And I think that generally speaking, for I'd say 90% of the folks that I consult with, there was always an elephant in the room. There was an increase in some kind of stressor or stimuli, whether that was an increase in actual workload being done or a stimuli from stress, going through relationship problems, job, sleep, stress, whatever that might be, that was recently, taking place that has now, involved or has evolved into something that led to some increase in pain, sensitivity, or injuries. And that's when we talk about workload management or the mechanisms behind that side of things. That's more of what we're referring to. When we talk about injury at large, I mean, the mechanisms are vast and wide and also poorly understood. And I think that that's probably the most skeptical thing that Katie and I talk a lot about, is that when people want to make very specific claims on what causes injury, such as very pathoanatomical things like posture or positions and Very common, I don't know, things that you may hear in a doctor's office or they get slapped around on social media or that even maybe a misinformed PT has unfortunately delivered. We don't have a lot of research to indicate the exact mechanisms for why people experience pain for different body parts or regions, and that pain is very complex, and that to be as reductionist to say it is 100% because of this one thing 100% of the time is probably missing a huge part of the conversation and is likely more unhelpful for most folks than helpful.
That makes a lot of sense. I try to point people to, perhaps it's an oversimplified dichotomy. There are certain things that are beyond our control, right? There's going to be some potential genetic predisposition to certain things, okay? But not to be like bound by that. There are certain things that more acutely we can manage, be alert to sleep. Acute sleep deprivation can be an injury risk factor. Dehydration certainly is one. I think we probably on average are better at controlling water than we are sleep. But then we also know that if you haven't slept all that well, going and getting a workout in actually helps how you feel that day. So like it's trade-offs, right? So even then I don't like to say, oh, you haven't slept all that well, you shouldn't do anything physically active. I think that's net detrimental. So I don't even like leaning too hard on these things. We know that previous injury definitely has a relationship with the risk of future injuries. And is there anything else here that you're like, hey, if you guys are paying attention to this, at least you're managing your day-to-day risk responsibly?
Yeah, I think I would 100% agree, first of all, with what you're talking about, sleep and even like nutritional stress or hydration. I think sometimes these things, we've gotten into a culture of like the optimization of everything. And if it's not optimal and your Whoop score isn't, ideal, then you just skip training. And that's a wildly huge miss. And people really don't need to become that concerned. However, I would say in the rehab space, a lot of people that we do consultations with or, we're doing evaluations for, they often are very, they're in a position where they don't understand where this injury come from. How could I possibly have pain? Or during the rehab process, they may be making progress for 3, 4, 5 weeks and then have a flare up or have a regression in symptoms. And to them, it feels random. And oftentimes they'll communicate the frustration of the randomness. And then usually when you start asking more and more questions and really breaking down what's going on in life and what's happening, there's always some kind of, insinuating factor or elephant in the room of like, oh yeah, I also did. Oh yeah, this also came up. And so it's not that any one of those things is going to inevitably cause a risk for pain, because we know that people get away with all kinds of things they have for their whole life. That's why it feels random, because they've probably done these things multiple times in the past and did not have a flare up. So it is far removed from their brain of why in this particular instance it may be causing this thing, because they've probably gotten away with it a lot. And now at this one point in time, for whatever reason, it is contributing. It may be a factor. So we don't need to get myopic or become neurotic about any of these one particular things. However, when you zoom out and you start looking at things from a bird's eye view and you're taking the totality of things that may be occurring in someone's life at any point in time revolving around a increase in pain or a flare up or an injury, there's oftentimes some clues that may contextualize why in this exact moment I'm having this flare up. And all that is not to become neurotic and start fixing those things. It's just to make sense of it. It's to help people navigate these things, to make it feel like it's less random, because when things feel random, it feels chaotic. It feels like it's out of your control. I think most people dealing with pain, whether that's psychological or physical pain, it's not that the pain itself is the biggest cause of suffering. It's the feeling of loss of control or the unknown, the uncertainty that people feel most uncomfortable with. In psychological research, when people are posed with 3 different options, it usually goes in this order, where people want to know if I'm going to have a positive outcome. Next, they want to know if they're going to have a negative outcome, but the least likely thing they want is to not know if the outcome will be positive or negative. That's the least likely thing that somebody will want. And people would rather know that something will turn out poorly than not know. And I think it's the idea of the uncertainty and not knowing that comes with, or that presents itself as more of this suffering that people deal with. And if you can help them navigate that and make sense of their pain and make sense of their situation, I think a lot of that sense making is what we do in rehab that actually, get people through these things.
The uncertainties part makes a lot of sense. You make me think about, I can't remember where it happened first, but it's sort of universal now, where people are frustrated, negative experience when it came to waiting for trains. And it would have taken an astonishing budget to have set up the systems to have all these trains, this network on time. What they did instead is they just posted boards that said how long before the train was coming. And as they studied this sort of thing, people were actually happier knowing that there was certainty of the train, even if the train time wait was longer than it would have been, but they just didn't know that it was going to be coming soon. So it's just a human need for certainty. And it makes a lot of sense when it comes to injury. And I can understand if somebody's dealing with pain, especially if it feels random, if they don't have a good handle on maybe they're, okay, I had done more, there's this sort of acute thing that might have contributed, then the fear of having this thing continue to happen again. I can understand why that would be stressful. We can go back to the start of the question and through sort of a different lens. It's funny, a good friend of mine sent me a video and it's some Muppet anesthesiologist. And okay, I have side quest. I do believe there are certain categories of quote doctors that should not be allowed to use the title outside of the immediate scope of what they do. And I think anesthesiologists are a very good example. If I have any listening, guys, I'm sorry, but this guy sort of ruined it for you all. And he was posting saying, oh, these 3 exercises, barbell lifts are, he's implying that they were inherently dangerous. And it was back squatting, it was deadlifting, it was overhead pressing. There's videos of like horrifically bad stuff. So I sent my friend a voice message reply and said, why, this is rubbish. I saw Adam Meekins had commented. Sure enough, Adam the next day had put up a video about it. And I guess here's what I would love for you to unpack this. We do know that barbell lifts are the lifts that, generally speaking, we can load the heaviest outside of certain machines, right? They're also the things that attract a certain demographic who are more likely to ego lift. But I guess it's probably a violation of, load management. Do you want to speak to this? Because we do have these examples every once in a while. Somebody, they die because they get pinned under a barbell. And of course it hits the cover of Generation Iron and it's sensational. And everybody uses this as, oh, it's inherently dangerous. You shouldn't do this shit. So do you want to talk more broadly there? And maybe, yeah, let's go there.
I think what's maybe frustrating about that rhetoric is that we don't apply the same things to how many runners die every year by getting hit by cars, how many cyclists die every year by going over the handlebars, getting hit by cars or other cyclists, other, incidents. And, so if we're going to say that participating in physical activity under a barbell is inherently dangerous, well, I think that we also have to look at what other physical activities could potentially pose risk to not just mortality, but also just to risk of injuries. And I think there's just as many, if not far more, runners or people who pick up running who will develop all kinds of tendinopathies, bone stress injuries that may cause quite a significant change in their life that they have to manage. Like a bone stress injury in general, I mean, you're looking at like 17, 18, 19 weeks dealing with a high-risk bone injury site that you have to take completely off running and like very slowly dose back in. That's a pretty significant amount of time away from the thing that you enjoy. And so when you do see these folks, like this video that you were mentioning of the anesthesiologist talking about deadlifts and barbell type work, well, that's a very limited scope. And maybe they're seeing that they're putting people under the knife for something like a back surgery, which is already from the outset overdone. It's over medicalized. We do far more surgeries on the spine than should be done. It's MRIs are far more done than they should be. Now the clinical recommendation is that in the first 6 to 8 weeks of pretty significant back pain, you should actually not MRI people because of the harm that comes with that, because of how people can become myopic about these things, how the surgical industry has really overstepped and done too much surgery, that the long-term benefits of getting surgery versus not getting surgery, not so good. Those who get surgery don't do very well in the long term compared to those who don't. So we've already made some oversteppings and some overpromising and misshaping that expectation from the outset. But that's their clinical lens, because those are the people that are typically going under the knife. So an anesthesiologist who's delivering anesthesia, that's probably what they're seeing. And maybe, the doctor is communicating, oh, yes, this patient has a herniated disc. They said that they got this herniated disc from deadlifting. However, if we look at the research and you take 80% of people just off the street without back pain and run them through an MRI, machine, a scan, you're going to see that they also have herniated discs and all kinds of degenerative disc disease and things that may indicate that they should have surgery, but they don't have pain, so we wouldn't do surgery. So then when someone does have pain, now you find this aberrant thing on an image, and now it says, oh, you know what? I found this thing. I know how to cut that thing, and that's what I do. I'm a cutter. I'm a surgeon, so I'm going to offer a cut. Well, that's not the only option when you zoom out far enough. And so I think that the question about injury and are the barbell lifts inherently dangerous, I think we have to really zoom out and say, well, participating in any physical activity at a level that you're not prepared for, it could pose an injury risk. And if you want to measure, okay, what are the actual big risks in terms of mortality or significant life changes, you have to undertake that you are taking a very significantly higher amount of risk by participating in recreational running and cycling than you ever would in a barbell situation in a gym setting. Even if you were just an ego lifter, it probably poses a far less risk to your life than participating in the alternative. And yet those things don't get demonized. And I'm not saying that either should be demonized at all. All of these things are inherently part of the human experience in life, the same way that driving your car to the grocery store is inherently risky, but it doesn't mean that you're not going to drive. So we still have to move forward as a human life.
A quick break from this episode to shout out RP Strength and the RP Hypertrophy app. I have a big confession. I've never used a coach before. I've always auto-regulated my training for decades. But I've known Dr. Mike Isertel and Nick Shaw, the founders of RP, for years. I'll get behind anything they create, including years of reading their books, consuming their media, attending their seminars, and having them as guests on the show. And I've been using the RP Hypertrophy app now for several months. And several things have happened. It forced me to make smaller and more gradual but better increases in weight volume across time, like putting 5-pound plates on each side of a leg press. Like, who does that? Never before. Only 45s. It cut out the jump volume. It made my workouts faster and more efficient. I show up with a plan. I didn't have to think about what to do. I feel more accountable having a lot of my progress. And I don't skip things because I don't feel like it. If hiring a one-on-one coach isn't for you, using the RP Hypertrophy app is the next best thing to manage your gains and to take the guesswork out of your program. There's a 30-day money-back guarantee, so you can try it risk-free, and if you don't like it, they'll give you your money back. I've also got you a $50 US dollar discount. So go to rpstrength.com/coats and use the code COATSRP, or go to the link below in the show notes. That's rpstrength.com/coats and use the code COATSRP. You touched on the analogy I was going to use. So of recent, I'm obsessed with the idea of having a self-driving car. I love the idea. This is my future. I want to have a vehicle that chauffeurs me around. I understand there's a whole bunch of positive potential implications from this, from being dropped off and it going in parking for you. But for me, it's just, I don't have to experience traffic. I will sit and I will read, I will work on my laptop, etc. But you hear about the rare thing where one of these self-driving cars knocks over a kid or something else happens. Are you guys familiar with the death rates on roads of human drivers and vehicles? So I firmly believe, I think I'll die on this hill, that we already have the technology. If we rolled out the technology as it is across the board today with self-driving cars, our roads would be safer than with human drivers. Right? Certainly think about the elimination of drunk driving, but the automated car that gets into an accident, kills a kid, etc., is going to hit the news in a way that the everyday traffic accident just gets completely ignored because we baked it into the risk profile of existing in our world. And I think it's a perfect illustration of this.
I agree. I think we tend to focus on inflammatory, sensationalized, novelistic things. And I think we have a sociocultural heuristic that lifting weights for whatever reason could be inherently dangerous. And I don't know exactly where that comes from. I do think that the medical industry has significantly contributed to that. But I also think that a lot of fitness grifters are trying to sell something that's alternative to the barbell lifts. They want to make themselves look like they have something special. And so if you can denigrate everything that's not this special thing that you do in your business and talk about these other things that they are so far risky and you shouldn't do that, well, that hits home for a lot of people, because a lot of people have experienced pain and discomfort potentially in the gym, or if they picked up something and they weren't used to that, they didn't have good programming design, they didn't know quite what they're doing, or even if they did and they experienced pain at some point, which is part of the human experience as well, then it's a very easy sell to say, see, reductionist, it's because of this, and that's why you got hurt. Just do my thing, my program, buy my specialty instead. And so that's an unfortunate reality that I don't know if we'll ever fully escape, but I'm hoping that, with more and more information, studies, and podcasts like these, that people can start getting a bigger picture and an idea of what is really being talked about here, that they can start having a little bit different mindset around these things.
I think there's another dichotomy that exists in our realm, and it's oftentimes in strength conditioning. And I'll give like the literal names and explain it. So I know, and I've had Mike Boyle on the podcast recently. I was in Boston attending an MBSC spring seminar. It was fantastic. And I mean, Mike's been a big influence in my career. Now, Mike is pretty strong in his opinions, and he doesn't include a lot of barbell lifts in his athlete programs. And this is the context I feel like people are missing, is they are building a program where they run a lot of athletes through in a system under the eyes of one coach. And I think it's actually okay to make trade-offs and standardize these programs. And because you're dealing with a bunch of different people, different limb lengths, different anthropometries, different injury histories, what have you, I'm comfortable saying I think there are certain implements, like I will barbell lift with some of my older adults. Like I got no problem with it. One-to-one, it's always individual to the person. But if you're fitting everybody into a system, it might be easier to do some of the things that I think are slightly more hypoallergenic than other things in terms of the potential trouble people can get themselves into. And this is what I think about. It's like, can people get themselves into trouble with this without, 100% supervision? And I don't want to fearmonger around it. So I get that position, which is often straw man from, and I find that Michael Mash, Barbell Rehab, he's a DPT, a friend, he's been on the podcast before. And obviously his messaging is like barbells are good, right? And I think these things end up in, and I don't see Michael fighting with Boyle, but there's a lot of other people actually will like to go at Boyle over what he says. And I often think that these people actually agree on 98 to 99% of people, of things. They will just cherry pick this one thing, slightly misrepresent the nature of it, and then get into a battle. And that stuff I find is actually not very helpful.
Yeah, I think that a lot of the narratives and messaging, not just that Boyle, but others may put forward, because of some of the absolutism, some of the nocebic narratives around it, I think it does cause more harm than good. And you're right, there's probably a lot that we actually would agree on. And that when you're looking at what was a message that was intended for one population or in one context, that then gets extrapolated to now this is just truth across all contexts, that's where in lies a lot of the problems, what you're talking about, and like how these things are communicated. And I don't think, I try to be very agnostic. I don't think that there's one specific type of movement or type of lift, or that will have to get under the barbell if you want to get strong. There's a host of ways to be physically active, to improve your life, to get generally stronger, to live a full, healthy life that allows you to do the activities that you would like to do. And I'm very impartial to whatever that looks like in people's lives. However, one thing that we can't get away from is the physiology and the psychology. That's something that Katie and I talk a lot about, is that both of those things, if you're going to make a claim, well, it has to have a biological plausibility. There has to be some level of evidence to really back that mechanism up. And if there's not, then you probably need to hold that claim very loosely, and you can't say those claims very strongly. And then you also have to consider what psychological downstream effects may this have, whether intended or unintended, on audiences that could be influenced negatively in this way from me putting forth this thing in this way. And I think that's where some of these fear mongering, some of the burning the barbells, some of the more like nocebic heavy narratives around the risks that people may be taking or how dangerous this can be. Just because you've seen people get injured doing certain things, that doesn't necessarily inherently mean that this thing is wrong or bad. We don't stop football from happening. We don't stop basketball from happening, even though injuries happen all the time in these sports. But, this is part of it. This is part of the thing that if you want to participate in this thing, you have to assume some level of risk. And there's no way to not have risk, because we know that if you're sedentary and you don't participate in physical activity of any kind, that's far greater of a mortality risk to your health and your life, your quality of life, as well as your actual chronic disease, accumulation and medication, and the over-medicalization and the non-sustainable healthcare model that we have in our westernized culture. Like, those things far outweigh the risks that you may be undertaking from a temporary musculoskeletal pain standpoint by participating even in egregiously ugly heavy lifting. So I think we just have a miscalculation sometimes in the way that these messages are put out. In a nation that's already averse to training, where we already fight an uphill battle, even with youth athletes of oversport specialization and not wanting to weight lift, not wanting to weight train because it's inherently dangerous and it's going to make my kid slow or he's going to get hurt. And that's probably one of the things that will be the gift that keeps on giving for that kid throughout the course of that athlete's life. And yet now we have this messaging that like somehow training and exercise is this mystical, scary, heavy is scary, bad thing. And it just makes people more and more decision fatigued and moving further and further away from where they actually need to land, which is probably being more physically active and training a little bit harder for a little bit longer. And I think that we mystify these things to a degree that it actually scares people away in an effort to try to sound like we're intelligent or that we're trying to do good. I think some of that messaging actually does a lot more harm than good for the general population.
I think this shows up in a few places in fitness. And I don't like this message, no matter its ideology within our space, that the industry is bad, modalities are bad, I am inherently virtuous, I have the secrets. And I see this in the context specifically of, okay, working out is dangerous, so you need to learn from me to do it safely, right? I think, and that's what you're more or less alluding to. I've also seen this with people, and oftentimes it's the more performative and empathetic types that I get a little hard on I'm a little tough on them when they get too far. But a lot of their messaging is how bad the fitness industry actually is, but yet they alone are a bastion of virtue and goodness and morality and empathy. And it's like, you're pathologizing everything either way. But on the topic here, do you think that's actually part of what's going on with some people? Are just the tragedy of the commons where a person is trying to make themselves look good and get business, and they don't understand the actual scale of harm by saying, hey, exercise is risky, come to me to learn how to do it safely?
Yeah, I see what you're saying. And that's a topic that crosses my mind really often. And even just in the last week, been thinking a lot about that. About how do you not denigrate or pull down something else while promoting another thing? And I think I have to make sure that I'm always, for myself personally, checking myself and saying, am I saying this thing because I personally want more business for me? Or am I actually saying this thing because I think it's generally the right thing for the most people, very utilitarian? And I try to err on that side as much as possible, where I just see folks wasting so much time, so much money, and spinning their tires on things that probably have very low yield and very low outcome. And I don't think that any of the messaging that I promote, I don't want to promote myself as being some kind of oh, well, I'm the guru because this is bad, you need to come to me. It's more of hey, these things are just generally not very helpful. This has been borne out in the research. And I see it time and time again with everyone who is consulting with me. Maybe it's time for a little bit different mindset here. Maybe there's some other things that would hit on the larger global problems at an epistemological scale that, we need to look a lot more broad at what is going to create a sustainable healthcare model, what is going to move the needle long term. I don't care if I personally benefit from it or not. I may not even be a PT or a coach in 5 years from now because I'm going to be so burnt out doing it. That's not why I'm promoting these messages at all. I just want to see the most good done for the most amount of people. And I see so many people go through years of financial suffering, years of loss of life, of quality of life, of the things that they are missing out on, all the things that they believe that they're fragile for and cannot participate in that they would really like to do. And many of these people, it's really not that far off of what they want to do. And their goals are so close, but they've been sold a message that they can't and that they're fragile and that they need someone to protect them and shield them and get them through. And you need to pay this person to show you all the tricks, or else you're just going to be this broken, fragile, frail human that can never do these things. And, unfortunately, they spend years sometimes just chasing this pandering model of palliative care, only to find yeah, you know what? None of that was really worth it. I've spent $3,500 now on this thing that I thought would be helpful. And I actually just ended up missing out on a lot of life, and I'm done with that. I'm ready for the next thing. So I think that a lot of these messages come from a place of not, at least for me personally, like I'm not trying to get more business for me. I just want to see good things happen in the industry. And I do unfortunately think that sometimes people do try to put themselves up on pedestals, and especially PTs, and healthcare folks. I think they want to, hoard in, or they want to corral or gatekeep so much of like, oh, well, we are, the specialist for this reason, and our degree gives us this right to say this now. And, we're going to tell you all the reasons why this is bad or why this is injurious. And so you need us now to be the movement specialists and the biomechanists to come in and like fix your problems for you. And I think it is really unnecessary. It's very frustrating.
And I think Katie Dabrowski will say this a fair bit, and I suspect you'll agree with it, that rehab should look like training and training should look like rehab. It's an oversimplification. It requires a little bit of nuance. But I can understand that maybe a decent part of the physical therapy realm that doesn't have the skill set of being a strength coach, because that's one of my pre-qualifications to actually work with a PT for any client, is they have to understand, value resistance training as, an evidence-based part of rehabilitation, and not just rely solely on the insurance-based model at the mills that run people through and only do passive treatment, right? And it's, again, a little bit of a false dichotomy, but we kind of know that that's kind of how it presents. I mean, I guess I can understand why that particular model of the PTs that came through that system and don't have the skill set could feel very threatened by strength coaches, evidence-based strength coaches, even personal trainers who are actually very smart to a lot of rehab principles, and feel like, well, they're actually encroaching on our scope of practice. What do you think there?
Yeah, I recently saw a post from a physical therapist, and it really made me think and have to kind of like walk through this in my mind, where they were saying that if we're going to be PTs, and then we are going to say how ineffective or how low value care some of these like very passive modalities are, or the manual therapy care side of things, that's maybe not good care. But then we're also going to say that we have mystified exercise to the point where, maybe we've gotten way too focused on movement optimism, or not movement optimism, but movement perfectionism, that like it has to look this certain way, and that we need to be these movement experts and train and coach and cue every little tiny thing and object and make things look so perfect to mitigate injury risk. And we're saying that also probably doesn't matter as much. And, then what is it that a PT does? And, I thought about that, and I was like, man, what a tragedy, an old school way of thinking about what the value is of a physical therapist. I think Katie and I see physical therapy as, okay, somebody's in pain. Or maybe somebody has a very relevant injury history. Maybe it's post-surgical. There are certain things, movements, activities, doses, frequencies that need to be respected. There are tissue healing times. There are like things that we understand about certain regions. But if a physical therapist is not also making sure that that person is meeting physical activity recommendations, that they have, maybe nutrition or a nutritionist on board for certain pathologies, because that will likely increase or play into how long they're dealing with this pain potentially, especially like if we're talking about something like bone stress injury or something like tissue healing. Well, we're going to want to make sure that their diet is somewhat requisite for that their metabolic health, even if we zoomed out further than diet, just generally metabolic health, like even for something as simple as chronic low back pain or tendinopathy, we understand that pretty clearly that someone's general metabolic health, and the better it is going to give them a far better prognosis. So if we're not checking these big boxes, then what does it matter if we're doing this one very specific exercise or this one specific movement, or some, you get on Instagram and I get infuriated with how many people are talking about something as silly as like, looking at the oblique lateral fascial sling. And that's the reason why, people have pain. And yeah, exactly. Just such an eye roll of like, really? That's the problem of all the things people have going on in life right now. That's the one we're going to focus on. There are so many bigger rocks to overturn way, 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 way before we even start touching that kind of a conversation. Even with high level athletes, they still don't do 90% of the basics right. So like, there's a lot of other things that we should be doing right first. And I think that, if all your scope of practice is for a physical therapist is that you're a doer, an operator, a fixer of the thing, and you're looking for short-term gains, making this person comes to my office and, they're looking for a relief of pain, and I just do the thing that relieves pain. Well, that probably makes a positive impact on the person's life in the short term, but that doesn't make a positive impact on the person's life for the long term. It doesn't help them manage future injury. It doesn't help them manage or mitigate future risk. It doesn't give them a sustainable healthcare lifestyle model or behavioral change. Like, there's so many other things that need to happen in order for that person to actually receive good healthcare. And I think that's where, the problems really start stacking up in the world of PT, is that we're very short-sighted and very palliative model. And I don't think that's a sustainable long-term care. And we have to start looking at bigger whole picture things that make the biggest influence on people's lives from a host of different factors that we know not only affect the thing that they're signing up for PT for, that they have ankle pain or they have low back pain, but we also need to try to mitigate the amount of risk in all other categories of healthcare by doing the physical things that we are qualified to do. And if you're not doing that, well, that is your job. That's part of the problem. So I hope that answers that question, or at least gives a good topic point.
A quick pause for a sponsor shout out. I've been working with Train Heroic for several rounds of my online programs, and I'm working on expanding what I offer through the platform. Train Heroic is easy to use, and my clients love it. And I have friends who've sunk tens of thousands of dollars in their own app while constantly worrying and hoping that it doesn't break. Using Train Heroic means no stress for me. I trust Train Heroic's long-standing reputation for quality as an industry leader, and I know their team personally, and they're quick to come to my aid when I break things. I sometimes break things. Train Heroic is also trusted by some of the industry's best coaches, including people like Joe DeFranco, Jason Brown, Vernon Griffith, Dr. Megan Sack-Buckbina, Mike Boyle, and Angus Bradley. And we've updated your free trial with more support from the Train Heroic team and to set you up and help maximize the platform's potential. You start with a 30-day free trial, and once you sign up, I'll cover your second month. You get 60 days free total. Start your trial at www.trainheroic.com, and when the Train Heroic team reaches out, tell them you came from me and Lift Free and Diet Art podcast, and they'll hook you up. There's some guests that I will ask a question, and they'll give a succinct answer, and I'm like, oh, I want to draw more out, and I burn through my questions quick. Then usually the best conversations are people who take something, run with it, and add a lot of very thoughtful nuance. So I can see why you play well on podcast. You mentioned the metabolic health side, and I recently had Katie Dabrowski on. She's been on my podcast twice. She's spectacular, and she talked. I saw her post about this. I want to have a podcast about it, and it completely changed the way I thought about this, because I didn't know this before. But the degree to which we get fat deposits into tendons, it gets into muscle, but I never thought about through the lens of how this affects pain. Tissue quality, though a nebulous term, encapsulates it rather well, and how this impacts outcomes when it comes to rehab injury. And it's brilliant. Now, of course, this is one of the problems where there sometimes can be, I think for a while there was a bit too much ideological pushback that most people wouldn't even dare say, oh, there's a relationship between your level of adiposity and injury rehabilitation outcomes. We now know that, well, this makes a ton of sense. And I think we've pushed past the point where we're going to worry about being yelled at by the extremists, instead go, well, we just want people to feel better. But it actually does stand to reason. And on top of that, if you're walking around and let's say you're carrying a lot of extra weight, extra body fat relative to your strength, then there's also, I don't know if this is, I'll call it an orthopedic cost associated with that too, right? The impact, whether it's knees or what have you.
Sure. And when we talk about like even fatty deposits, on the other side of it, you can get glucose and sugar crystalline deposits in things like tendon from a inability to uptake glucose well, and we deal with insulin. So, there's a lot of things that may go in, even from a neurological standpoint, which Katie could probably speak a little bit more to. But even in neurology, we understand that metabolic health and neurological factors and nociception, the sensation of pain is changed even by things like the immune system and immune globulins that are not well regulated in people with poor metabolic health. So there's such a host of things that are hammered on when people, even if you are not ripped, and you're not jacked and you're not incredibly fit, the act of participating regularly in physical activity that is somewhat difficult, moderate, even high intensity, to whatever level that is for the individual at that time period in their life, given all the circumstances, that has a very positive effect on people's pain. It has a positive effect on their metabolic health. It has a positive effect on all kinds of things that are related in the wheelhouse of healthcare. That if you're not doing those things or showing people or giving them entry points, helping them understand what are the red flags, what are we going to possibly avoid, what are the entry points of what you can do, and then setting the parameters of the dose and the frequency and helping them navigate and find strategies that are feasible for them in their life, then you're totally missing out on 90% of what you should be doing as a healthcare provider when we know that these things have such a massive impact. Now, obesity in general is an extremely difficult topic. It's seen now a lot more of a disease, less so of just willpower. I mean, I think if everybody just could try harder, there wouldn't be a whole lot of people experiencing obesity. It's not just about trying harder, having more willpower. And I think we unfortunately deem people that are not physically active or not physically fit as people who are just lazy. It's not that. So there's a lot of contextual and social factors that play into that. But as a physical therapist and dealing with folks with pain coming to us that have injury or they're currently just experiencing long-term pain, I mean, one of the biggest things that we could do to impact their life in a positive direction that hits on a host of things, not just pain, but everything else that may cause them pain in the future, everything else that may cause them medical distress and burden the healthcare system, not just from a healthcare standpoint, but even their own standpoint. I mean, going to see a healthcare provider and having to get medicated, that's a time cost. That's a financial and time cost for them that's very difficult and challenging, especially for people with low socioeconomic status that may not even have time to get an appointment, let alone they may not have good insurance to cover that appointment. Like, if we can do things that preemptively cover so many domains of what it is to be a healthy human and extend their ability to live a high quality of life without having to take part or participate in the systematized healthcare system, you know, that's going to be a positive thing for them. And I think that's just one of the biggest things that we touch on, whether we're talking about, low back pain, whether we're talking about tendon pain, bone stress injury, coming back from surgery, is just how do we mitigate some of the overall systemic problems in healthcare. And the way that PT is typically practiced and the way that it's poised on Instagram as these quick fixes or come see me, I'm the operator, I'm the master, I'm the guru, take my classes, take my courses to figure out how you too can become a guru and fix these problems that no other clinician can. It's a really bad look on healthcare. And I think that it just keeps people in the loop of searching for the fix and seeing all the trees in the midst of the forest and never zooming out far enough to see the forest for the trees.
How do you navigate this? Because this topic comes up usually with doctors in general and the weight, the adiposity and weight of an individual coming in. Let's say they come in with pain. So we can now extend this conversation to a person coming in musculoskeletal pain as they're experiencing it, and they happen to be overweight. Now, we know that metabolic someone who can be in a normal BMI but still be metabolically unhealthy. In fact, there's a lot of people walk around that way. But there's a significant relationship between adiposity and poor metabolic health as well, right? We're no longer kind of in this fairy tale denying that relationship, especially as you scale it over time. So how do you actually approach this in a respectful manner? Because the flip side, and the reason why we have this discussion, is because for so long, people are coming into doctors' offices and they're immediately, the doctor's making assumptions and saying, hey, you need to lose weight. And we also know that it can contribute to a massive array of health problems. But what often happens is sometimes it's independent of that. And there's some health condition that gets, in the cases that hit the news, well, it got missed. Something wasn't diagnosed because the physician wasn't listening. And a lot of times it's bedside manner is the problem in this conversation. And now we have the people who come into offices and they'll have the card and say, please do not discuss my weight unless it's, specifically relevant to this. So how do you, as a physical therapy professional, how does the personal trainer who's trying to help someone, and even the listener who's the enthusiast who's trying to figure their way through this stuff, how do you have that conversation in a respectful manner that actually helps the person who this probably is, at least in some part, impacting their musculoskeletal injury experience of pain?
I think this is a great question because it's a touchy topic, isn't it? And it can be sensitive. And it is difficult because we certainly don't want to come into a conversation and say, oh, well, the reason why you have pain is because of your adiposity. The reason why you're not making progress is because you're obese. That is certainly not the message at all that I would ever recommend or ever give anyone. Now, I think where I come into this conversation, similar to any touchy conversation, any even disagreement in what you have in the treatment path forward, it comes down to informed consent. And how we make things consented is you simply pose topics and let the patient or the client choose which of those things they want to intervene on. Now, I can still say to the client, listen, we know that overall metabolic health, the general physical fitness of individuals experiencing pain, they will experience less pain and maybe experience pain for less time, or they will be able to do more in spite of having their pain if they're more physically fit. That is something that we can meaningfully impact in our work together. Does that interest you? Is that something that you would like to work on? Does that seem like something that is a feasible thing to work on right now? And if not, okay, next topic. What other things do you feel like are the meaningful things that you would like to intervene on? Now, some people, they may have it in their mindset that the only reason, especially on my end of things as a physical therapist, they may think that I'm just here to get rid of this pain. I'm just here to make this thing feel better. Now, I think where physical therapists really drop the ball is that, okay, if you just want to get rid of pain and you're paying the service, then I'm just going to provide this service for you. What that does is it just creates and repeats the same model, because oftentimes people have these beliefs or they think that, this is the only thing that matters, and just trying to help them see the bigger picture can be helpful. So if somebody says that they would like to just get rid of this pain, I would steer the conversation of what would you do if you didn't have this pain? What would your life look like if this thing wasn't a problem? And just help them explore, like, here's all the things that I would love to do. And then you can start weaseling back in or weaving back in. Okay, well, what amount of those things do you feel like you can do now? And could I show you some ways of these things that you're telling me are important to your life? Could we find some entry points that could actually get you to doing that thing, even if your pain wasn't entirely gone just yet? How does that sound to you? I mean, are you willing to explore a path where I still am dealing with a little bit of discomfort, but I'm able to do all of these things that really actually matter to me? Would that decrease the suffering and the meaning of this pain in your life meaningfully? Okay. Like, there's a lot of discussion points that we can start traveling down without necessarily having to look them in the face or have a pointed discussion around you need to lose weight, because they don't need to do anything. What they want to do is they want to get back to doing the things that they're missing out on in life. They have sacrificed or they're suffering in some way because this pain is now detracting from some experience in life. And getting to the root of what are the experiences that matter to you? What are the experiences that you're feeling like you have to modify or miss out on because of this thing? And how do we find meaningful entry points back into those things that do mean something for you? Okay, well, those are all good topics of conversation. And then just simply helping them understand or having a conversation and saying, listen, we can do some things in the short term that will absolutely help the pain. However, no amount of me massaging or dry needling this thing over the next 2 years of your life is going to make sure that this thing is meaningfully different forever. And that if you want to keep coming to see me, twice a week to massage or needle this thing, that's going to be a huge financial and time burden to you. And I really don't think it's going to move the needle in the long term in these things that you're telling me really matter to you, actually. Even though the pain is in the way, that's just a distraction. That's just the barrier right now. That's not really what we need to fix. All these other things that you're missing out on in life, that's probably what, I think it sounds like it probably matters more to you. And if that's the case, well, we need to start finding some ways that we can actually move the needle long-term on a lot of these things. And would you be open to exploring that path with me? Now, some people may just be resistant. And you know what? I'm not for everybody, and I know that. I'm not going to fix everyone. And if they just literally, that's all that they want is temporary pain relief, well, I'm probably not going to be the guy for them. Because that goes against all of my ethical beliefs in what it is to be a healthcare provider. And they're going to have to find someone else that's willing to practice what I feel is kind of unethical, and ethics, just giving the patient what they want, that's a debatable topic potentially as well, especially in the world of pain and PT, but that's probably just something that I'm personally uncomfortable with and not going to do, because I know that it probably will not be a sustainable model for the person. It's going to drain them financially or time wise. And frankly, I just don't think it's a long-term solution. So I hope that answers some of the question. Is just the other types of questions that you can ask that don't have anything to do with their weight. It's just more of like, what do you want to do in life? And I think that there's probably meaningful paths forward that you can do that thing if we work on metabolic health, because guess what? Even with pain, there's a lot of things we can do to impact this other thing that meaningfully benefits you. How sweet is that? Like, that should be liberating. Like, holy shit. You're saying there's something I can do that's super positive, not just for my health, but also for this pain that will give me long-term standing benefits for the rest of my life. Like, yeah, show me the way. Cause like, where's that? That's a miracle drug if you got it. And as long as people are on board with taking that time and willing to navigate that with you in a way that means something to them, that feels feasible, like, dude, you are a therapist. You are a coach. That is what your job is.
I find that people self-select to our world because, again, I'm not a physical therapist, but there's enough adjacency here that same type of people who will come to someone like you or Katie are probably going to end up in my hands, strength training. And I find that strength training is the road through everything, because if we're trying to improve metabolic health, strength training is one of the best things there. I mean, sure, there's absolutely a very big impact on losing 5 to 10% of excess adiposity, or total body weight that has, very big effects on long-term metabolic health outcomes. But I still think that underpinning it all, if you get someone to like strength training, get them stronger, that's going to have a big impact on their metabolic health. Here's a side thought. I think we can just a quick answer and clue up here, because technically speaking, recommending GLP-1 agonist medications is beyond both of our scope of practice. I said the word recommend, but we often end up discussing these things with people because they come in and their goal is weight loss, more so on my end, perhaps than yours, but I suspect still. And I recently had a conversation with Dr. Jordan Feigenbaum episode, if anybody message me if you want it, where he talks about how a lot of these drugs actually preferentially don't just better at pulling fat deposits out of things like liver fat, muscle tissue, et cetera. And I mean, where's the line with actually recommending? Or is it explicitly outside of scope to say, hey, I'm recommending someone explore the possibility of looking at a GLP-1 agonist medication or the new generation of drugs as something that could have a positive impact on their pain?
Yeah. Well, even if we wanted to zoom out further and say we can recommend strength training, for example, and we do know that strength training would be good for metabolic health, though someone does not need to become measurably stronger or improve their 1RM to improve risk factors or to improve pain. They just need to engage with it. And I think that now, to zoom in on GLP-1, I think there's been kind of an interesting psychological thing that's happened in some of the fitness industry where people feel like, oh, GLP-1s are bad and you need to do it the hard way and, get your willpower and you need to do it the way we all used to do it and grind through and suffer. And I think that's a really big miss, because, we can't argue and advocate for population level health and then not recommend or not advocate for in some way, or at least encourage or put in some kind of a positive light a drug that is massively effective at improving the things that directly relate to mortality rates, that directly relate to quality of life, that directly relate to so many downstream things. And I think that if we can get downstream of these problems and help people have access to these types of medications, I think that it's requisite that we make that known to them, that it is an option, and potentially work with a provider in your area that may be, a little bit more expertise or have the ability to recommend certain doses and manage the blood work for these folks and get them on a GLP-1. I think that would be something in the realm of healthcare, in the realm of weight loss, that, like, yes, absolutely. I think that there was even a drug that just passed its first human trials that it's like a gene modifier that was shown to reliably alter your LDL cholesterol, like permanently. It changes a gene that causes permanent LDL changes in people that have chronically or hereditarily high LDL levels, and like things like that. As more and more of these types of drugs and these pharmaceutical agents and solutions come available, especially in light of the very low risks that are associated with these things. And on the upside, how many positive benefits are there to people's like lives and mortality rates and medication. I mean, gosh, I think we've really got to start recommending these things, or at least putting these things in a very positive light and not shying away from it when it has so many downstream positive effects.
My thoughts align with your own. I'm actually very happy to hear you so bullish on them. And I think as more like, whether you say it retatrutide or retatrutide, once that comes online, because that's looking very promising in the trials. And, you know, as more and more of these drugs get mainlined, I think there's just so much potential here to affect, as you said, society's metabolic health at scale. Everybody can follow you on Instagram at coach_Q_physio. Anything else you want to point people to? I know you and Katie have been working on some stuff.
Yeah. Katie and I do a lot. Katie Dabrowski. I'm assuming folks have probably already listened to her episodes.
so.
They listened to this one. I hope so too. We're going to be doing a lot of speaking seminars of the Training Equals Healthcare. We also have a program together called Confusingly Jacked, which is more of just a training program if people are interested in that. And then I run with the First Principles of Movement, Craig Liebenson, an online mentorship group that people can sign up for. We do like journal club discussions and article topics. This week on Sunday, we're covering femoral acetabular impingement. We've covered a lot of other things, you know, in the tendon space, bone stress injuries, like there'll be lots to come. So, there's a couple of different things. I just put out a change of direction course on, basically how to program and walk people through a rehabilitative or even a performance change of direction program guide of how to program change of direction based training, because that's a huge gap, especially in the rehab world. So giving some contextual stuff around ACL, Achilles, knee tendon, hip related stuff for change of direction training as well that people can check out on my page.
Everybody at least start by following Q. Okay. You are a fountain of knowledge. I love the way you present information, just the nuance, the thoughtfulness, rooted in evidence-based practice. You're surrounded by great people. Anybody listening again, if you want, message me. I'll send you the Katie Dabrowski episodes and anything else that we referenced here. And Q, you will be back as long as you want to. You make a fantastic guest. Thank you guys. Go support him, check him out. And then as you deep dive, who knows, maybe you'll get into more of your work. Thank you. This was wonderful. Appreciate you.
Appreciate having me on. This is a great podcast and a lot of respect for you. And so appreciate this opportunity, brother.
Thank you.